Hello, Nav here, plastic surgeon. Welcome to the Real Clinic podcast, sponsored by 42 South Films. This is where we take a behind-the-scenes look at the surgery industry, get to meet key players in the business, learn about setting up a clinic such as Real, and meet some of the best surgeons around. Today I've got a really special guest for you. I've got Nora Nugent, the current president of BAAPS, the British Association of Aesthetic Plastic Surgeons. We're going to talk about BAAPS, the kind of projects that it's been involved with, and there's lots of really interesting topics that you'll want to hear about. Going to talk about Nora's reign as president and some of her own special interests, not only clinical but also regarding her other sort of business hat, being a sort of clinic owner as well. So, hi Nora, welcome. Thank you for coming all the way down to deepest, darkest South London.
Thank you, Nav. Thank you for having me. It's good to be here.
And so, yeah, I mean, my opening gambit question is always the Cilla Black blind date question, which is, what do you do? Where do you come from? So tell us a bit about yourself. Tell us how you've ended up here. Go as far back as you want, right into your early childhood, whatever really. Tell us all the interesting bits of your life so far.
Great. So I'm Nora Nugent. I'm a plastic surgeon based in Tunbridge Wells, and I am in full-time private practice with interest in aesthetic face and breast surgery. As you said, I'm the current president of BAAPS, and how I got where I am, it goes back a little bit further. I came to the UK initially in 2012, and I took up a post at Queen Victoria Hospital in East Grinstead, and that aligned with my reconstructive interests at the time. Private practice came out of that. How did I end up in East Grinstead? Well, that was a step back again. I was in Australia before that. I did my training and grew up in Ireland before that. And really, the post in East Grinstead grabbed my attention because it covered my reconstructive interests at the time. It obviously has a very good reputation, and this was a temporary post in the beginning. So I thought, why not? Let's go and spend a little bit of time there. And 14, 15 years later, I'm still here.
So let's talk about your training, because you did do your higher surgical training in Ireland, I believe.
I was born and raised in Ireland, and I did my medical training at UCD, University College Dublin. Started my intern training in Dublin, basic surgical training, Dublin and South East. And then before I started higher surgical training, I actually did a year in Texas first. I did a 1-year fellowship in Galveston, burns and critical care. Then I did my higher surgical training in plastic surgery and did fellowships in Australia and finished my training in Australia.
I've always wanted to know about training in Ireland, because it seems, maybe not the high surgical stuff, but which you wouldn't necessarily, you did do your high surgical.
Yes,
so, okay, let's talk about that as well. It seems like it's always seemed really tough to me, and I don't know, compared to the UK system, that even when I was training, the stuff that you guys went through in Ireland, it all seemed very kind of, I don't know, old school is probably the best way to put it. Is that fair, or is that not fair?
Fair, but with some nuance. So it essentially was a little bit like the older style training in the UK, prior to changing, for example, titles to specialty registers rather than SPR. The European Working Time Directive, let's say, wasn't implemented quite as readily in Ireland. So, we didn't really change how we worked when that came in for quite some time. And it was probably more the older style of training in terms of taking care of things with less supervision. I would say there is good and bad about that, because it did give us a lot of operative experience. We did have to become competent at decision making, and it that stands to us in the long term as well. But obviously, some things could have been easier. But it has moved more towards how things are in the UK now, and I think that's always the case, because we're aligned in terms of curriculum and exams under the intercollegiate umbrella. So although we arrived at the end point in a slightly different way when I went through training compared to my English counterparts, we were supposed to be the same. We were supposed to have undertaken the same structure and training.
And then what about, because Ireland is obviously still in Europe, and we're not here in the UK, but the Irish colleges are aligned with the UK colleges. So how does that now work? We'll move off training in a minute, I promise. But how does that work in terms of kind of being, European working time directives and the rest of all the European training directives
So,
and UK?
so I'm going to say probably from a European training directive, things have changed since I last worked in Ireland in 2010. But certainly while I was there,
Was it being ignored?
Everybody wondered what we would do when it came in, and actually we did nothing. We just did exactly what we always did.
Yeah.
But in terms of training and structure, the Royal College of Surgeons in Ireland, which is based in Dublin, is the college we did our MRCS and FRCS through. But it's effectively the same exam and the same certificate that's awarded as the Scottish and English colleges. It's just awarded by the Royal College of Surgeons in Ireland. And in all honesty, Brexit didn't make any difference to that.
Yeah.
And it hasn't made any difference in terms of recognising qualifications.
Yeah.
There's a common travel zone between Ireland and the UK, common recognition of qualifications. So it really, that's probably one aspect that Brexit didn't affect.
Yeah.
And so it hasn't really mattered from that aspect, being in the EU or not.
And then are you guys now post-Brexit, because we're seeing fewer Europeans coming here because it's just more difficult? Have you seen an influx in Ireland, I mean,
not that I'm aware of,
Yeah.
but I'm not actively involved in that.
Yeah.
So it may be happening, but I'm not aware of it.
I just wondered. So, and then Australia to do what, microsurgical fellowships?
I did microsurgery, aesthetics and hand surgery in Australia. I spent a year in Sydney, and then I followed that with 6 months in Melbourne. So I did quite a broad range. I liked variety. And also at the time I was planning to go back to Ireland, and you needed a slightly broad spectrum of skills. It wasn't going to be, if I had gone back, it wouldn't have been a super specialised post. You would have needed a range of skills. You can have an interest in a particular area, but a broad range of skills would not go astray. I also liked the variety of it. So I ended up in Sydney doing microsurgical reconstruction and aesthetics, and then a hand fellowship in Melbourne.
Okay, cool. And then if we now leap, let's skip to, because everyone knows what you would have done as a consultant in the UK, given our primary audience. So, but you got to a certain point, and I don't know how long you were a consultant at the Queen Vic.
10 years.
10 years. So what happened at the end, or what had changed, or what was it that then made you leap from NHS and private, which is, I'm guessing that's what you did, a bit of both, to going purely private? Talk me through that. You got totally cheesed off or whatever,
I didn't get totally cheesed off. I did, as you said in the beginning, I had a private practice running alongside my NHS practice, like most of us have done. And both sides were getting busier. So that was one, it was harder to balance them. The NHS, I had a very nice post at the Queen Victoria Hospital, and it was a very nice department to work in, but I found the NHS getting to be a little bit more frustrating to work in, in terms of being productive or being able to get change. The wheels turn very slowly. This was obviously just after the COVID period when I left as well. I left the NHS in April 2022. So it was a combination of those reasons, and also I like change, and it was time to change as well. So it wasn't entirely the NHS. It was partly the NHS, and it was all partly me. Okay. Yes.
And then, talk us through how that's worked out in terms of, since you've gone into partnership with Mark Pacifico at Purity Bridge, because you're now a co-owner of the clinic with him. So before we get on to sort of clinic ownership and business and so forth, how have things evolved with your practice, your clinical practice, and the rest of your life? Because I think people often think, oh, maybe I should quit the NHS. I think about it every day. Every time I go into the NHS, I think about maybe it's time to quit. And then I go and I actually have quite a fun day generally. And I go, okay, another day, I'll stay. But so how's things changed, presumably for the better?
Yeah, so from a working point of view, things have changed for the better. I have more control over what I do. I'm not necessarily quieter. I'm probably busier now, but it's set up more how I want to work, and I've more control over that. The one thing I missed when I left the NHS was my colleagues. There's a very good plastic surgery department at the Queen Victoria, and obviously I'm still in the area and I still see see them when I go to hospitals in the region, but it's not quite the same as working in the same department. Coming back to the clinic, my private practice has always been based at Purity Bridge, but it's obviously it's there in a different capacity now. The clinic was set up by Mark in 2013, and when I started private practice, I based my office there, and I practiced as a plastic surgeon there throughout that time. But when I left the NHS, I was obviously focusing full time on private practice. There a lot more, could devote more time and attention to building my practice, and that felt like that was the right step for us. We've worked together for a long time. We know each other very well, so we could work. We felt we could work together very effectively, and we felt we could work. We know that a lot of partnerships end in disagreement and dissolution.
Yes.
We did take a while to get to being in a partnership at the clinic, but we felt we had a good working relationship. We had a good interpersonal relationship, and that also we'd be more effective as a team than either of us individually. And so that's how it evolved.
So okay, and then BAAPS. Let's get on to BAAPS now. You're the big presidente. How's that going? You know, because you're coming towards the end of your tenure. Because we're recording this in March 26.
Yes.
You will come to the end in October 26 at the next meeting here in London. Talk about. Well, I tell you what. Let's start at the beginning of your BAAPS career, so to speak. So how did you get involved in BAAPS? Because I've been involved. I was briefly on council, because I think people will also want to know how to get involved in organisations such as BAAPS and BAAPS and ESAPS and so forth, and ESAPS as well. We can talk about as well. How did that all happen?
So it started back in 2017 when when Simon Withy was president, and at the time, Mark Pacifico was, I think, an honorary advisor or a member of council. I can't remember which. And the project that people wanted to start in BAAPS was a video library, an educational video library, and they needed someone to look into that and spearhead it. And I don't specifically know who suggested me, but someone did. Maybe Mark, I'm not sure. And Simon Withy called me up and asked me if I'd be willing to do it. And at the time, I said yes. We kind of mapped out the curriculum. I got involved. We actually got in touch with Nadine Haram Hadash with Proximy. We got some videos recorded. But being honest, the project stalled a little bit. And I think I can say maybe we fulfilled it this year with a QMP subscription. So maybe a good almost 10 years later, I've actually fulfilled the remit I started with BAAPS for. That was my very first contact other than being a member. And then that led to being asked to put myself forward for election to council the following year. And then I've actually been on council since. I was elected. I was then part of BAAPS support, and when Mike Tyler had to demit in COVID for other commitments, I took over as chair of BAAPS support. And then that led to staying on council and eventually vice president and president. It all stemmed out of being supposed to create a video library.
Nice. I guess that's how. But we can all trace our careers back to little moments like that, isn't it? And then, what's it been like being president? So, what does that involve for these last almost 2 years?
I'm coming into my last quarter now of the 2 years, and actually, it's been good. It's opened my eyes to how some things work. You know, when you're directly involved, you see more of the internal workings of some organisations. There has been a lot of stuff over the last 2 years. My term started the week that we had a very unfortunate incident, the death of a woman from buttock filler. So that happened the week I started. So a very auspicious start for aesthetic surgery.
Thrown in front of the TV cameras and all that sort of stuff.
So I spent a lot of time talking about buttock fillers for the first couple of weeks, and we're still talking about it. But we've had a lot going on over the last 2 years, as well as the usual education programmes. We've added a new meeting, Face, Eyes, Nose, which we're going to do. It's been running for years with Rana Dasgupta, but we're doing it under the auspices of BAAPS in May. And we've been involved in a lot of regulatory discussions as well. We've a huge amount of movement in the non-surgical arena for aesthetic regulation at the moment, particularly in Scotland, but the UK is following. And we had a parliamentary inquiry earlier last year as well.
So let's talk about that actually. What was all that about?
So this was the Women and Equalities Committee, which is one of the parliamentary select committees.
Yeah.
And the inquiry had quite a broad remit. It covered breast implant safety, cosmetic tourism, and non-surgical regulation or lack of regulation.
Yeah.
And it heard from quite a broad range of people. I represented BAAPS. Elaine Sassoon, who has an interest in regulation, represented BAAPS, and Rika, who's also part of BAAPS, represented BAPRAS on it.
Yeah.
So we gave oral evidence at one session, and I have to say it was a very tight agenda because the remit was huge.
Yeah.
But they covered ground quite well during that consultation, and we did get a chance to say more afterwards to try and expand on some of our views and send in a written report. The report's only just been published actually, and it has recommended quite a few of the things we suggested. It maybe doesn't go quite as far as we would like in some areas, but along with the non-surgical consultations that are going on, it's quite a big step forward, and I think now is the time that we might finally see some movement.
And so for a member of the public that might happen to be watching us, what are the key things that they can expect to be better as a result of this?
The key thing is safety and being more assured that whoever you are seeing for an aesthetic treatment is qualified to actually give that treatment, and for the more invasive treatments that they will take place in a healthcare environment with a healthcare professional. It sounds obvious, but as you and I know, it's not always the case.
And so is that happening now for fillers, for example?
It will in Scotland. The legislation for Scotland is at the last hurdle, not quite in law yet. So we all know these things can change.
What's happening there then? So you can only inject filler if you are a doctor, nurse, dentist. Is that basically? Essentially,
but what's broadly happening, and the consultation and proposals for England are going to be fairly similar. Broadly speaking, non-surgical aesthetic procedures will be divided into three categories. Level 1 or green, depending which jurisdiction you're in, where the level of risk is lower in terms of complications and the level of complexity is lower. For example, very superficial facial peels, hair removal, very light treatments and facials, and essentially they can be done outside of a healthcare setting by a non-healthcare professional, for example a beautician. The middle tier, amber as they will be in Scotland, are quite a broad group, things like derma fillers, Botox injectables, deeper peels, deeper lighter laser treatments, but not the very deep laser. And these can be done by non-doctor healthcare professionals, for example, nurses, or under the supervision of a healthcare professional and in a healthcare setting. And then the higher level or red category are those that are a higher complexity to perform and have higher risk, or both, and should be performed by doctors only and in a healthcare setting. So this will translate into a licensing scheme, and HIS in Scotland will oversee the healthcare aspect of it.
And the top level is essentially surgery, is it?
Ablative laser, so deep laser, more complex dermal fillers. Possibly PRP, so some of the more higher risk or complex injectables, essentially. And the deeper ablative treatments with, for example, laser.
And have you got a guesstimate when it might hit the UK?
So the Scotland will probably pass it into legislation in the next couple of months. The UK has done a consultation on it, and we've just had a series of meetings that are coming to a close with the Department of Health to flesh out what similar levels. I think they'll be called something slightly different, but similar model in the UK. A few details to be ironed out, and then I think there's going to have to be another consultation in the UK. There's already been one, and then legislation.
How long does that take?
I don't know. In all honesty, I suspect it maybe another year. But if it becomes into law in Scotland, England and Wales would be under more pressure to follow. It can't be too much out of sync.
And what other bits, you said it maybe doesn't go far enough. What are the things that you're thinking you
wished? So some of the dermal filler, the middle group, I would be stricter on in terms of, I would classify it as high risk and doctor only. So some things like that I would be stricter on. I also, in the early proposals, and this is a particular bugbear of mine, when the early consultations are released, in both England and Scotland, liposuction and fat transfer appeared as a non-surgical procedures, and to me they're very much surgical. You know, what do people have? What was a BBL that we heard all about?
Yeah,
you know,
exactly. Yeah.
So that I think we've succeeded in moving those off.
Good. Okay.
And that they're
In
surgical.
Scotland as well?
Yes.
Good.
But we have tried to make clear there are two things that need to happen, and I don't quite know how far we've gone in it yet. One, we can't have a situation where non-surgical is more regulated than surgery.
Yeah.
Which could potentially happen. So basically surgery needs to follow and be more specific for cosmetic surgery as well. And two, we need to make allowance for new procedures and new techniques coming on board and how they would be categorized, because otherwise you'll have parallel systems of regulated and unregulated treatments.
Yeah.
So those two aspects are still being fleshed out to some degree.
And then just one more thing. When you say doctor only, is that not even dentist? Because dentists do a lot of non-surgical stuff in the UK.
So for some things it could mean dentist, but for other things, like I'm just going to put buttock fillers out there as an example, as it would be doctor.
Yeah. Okay.
And maybe even go as far as specifying what kind of doctor, for example, plastic surgeon or something like that.
Someone who's maybe got the certification from the college and all that stuff that's being piloted.
Yeah. But some of this is yet to be finalised.
Yeah, no, but
it's still a big step forward.
The sooner it happens, the better. If you ask me, I think that's what all of our colleagues think. Yeah. Good. No, that's good news. So and then the other. So that was regulation during your time at BAAPS. Talk us through the other kind of big, I don't know, projects, as it were, or the big things that happened.
So we've had a couple of things, and some have been more via BAAPS support than BAAPS. BAAPS support, for those who don't know, is a company rather than a charity, but under the it's set up by BAAPS, and it can provide more sort of business support or direct member benefits out with the charitable aims of BAAPS itself. So we've obviously had a lot of interest in some of the VAT and aesthetic processes that have gone on over the last year or so, and we've also tried to expand our educational offering. We've done that via running Face Eyes Nose, and also by including Q&P subscription to their video library for BAAPS members as part of the membership. So that has expanded our educational offering quite a lot. And then we've worked as well quite closely with the Aesthetic Surgery Journal, which is owned by the Aesthetic Society, but is the official journal of BAAPS. And we've produced a supplement with them focusing on the benefits of what we do, the health benefits more specifically, because we hear the negative news all the time. But as we know from our clinics, there's a hugely positive side to aesthetic surgery and aesthetic treatments as well.
And is that supplement, by the way, available to the general public?
It is published by the ASJ. It is currently either subscriber or purchasable, but we are looking at making it more open access.
Yeah, I think that's a really good idea, especially again, coming back to it.
Stay tuned.
This podcast is mainly targeted at colleagues, old and young.
So anyone with a BAAPS membership will have ASJ as part of it, so would have full access. We're looking at seeing how we can change go for a slightly more open license. So watch this space. Hopefully
really,
by the time this is broadcast, we'll have movement on that.
And so what if we just before we move away from BAAPS, being BAAPS president is a busy job.
Yes.
It takes you all around the world. It keeps you have to go and attend God knows how many meetings about who knows what. What are you going to do come October? What happens after that?
Well, in October, I hand over both BAAPS and ESAPS, because I'm currently president of ESAPS as well. So in my mind, I will have a lot of spare time, but I'm not so sure that will materialise. And I hand both over in the first week of October. We're having a joint meeting in London. I'm planning to have a holiday the second week of October, and then definitely it would be nice to have more free time, and definitely it will also be nice to have more time for my own practice as well, which at times has been a little bit shortchanged over the last 2 years.
Yeah, absolutely, I'm sure. And then actually I forgot to ask you about ESAPS. That's the European Association.
Yes.
Tell us a little bit about that and what you've been doing with that.
So that ESAPS is the European Society for Aesthetic Plastic Surgery. And again, I got involved in that as the BAAPS representative, and then that translated into being on the board and now president. ESAPS is an organisation that has similar aims to many of the professional societies in terms of improving patient safety, but it also looks to sort of unite across Europe, across common areas of mutual interest. There are some common logistical and regulatory problems all across Europe, and to provide a European voice or European cohesion on those topics. Breast implants and implant registries are one example of things like that we're trying to see how we can help from a European perspective and hopefully produce some consensus documents on some of these things as well.
And who takes over from you in BAAPS and who takes over from you in ESAPS?
So for BAAPS is Anthony McQuillan, who's based in Bristol. He also comes to London, but mostly based in Bristol. And for ESAPS is Pier Francesco Cirillo, who's based in Rome. Nice. So that goes to Italy next.
Oh, yeah. So big shoes to fill.
Yes. Well, I don't know.
Let's move on to your business hat, I guess. So and I this is something that I've where we've got similarities with the Real Clinic here. So how's that been in terms of becoming a partner or a joint owner? I don't quite know how you and Mark see yourselves in Purity Bridge, but talk me through how that evolved. The how, the why, and where you're at now, and how it's going.
So the why was because we felt we would be more effective as a team.
Yep.
We've been working alongside each other for a very long time in the same building, but as separate entities, and we work well together. So that's the why. Yeah. Now that I was full-time private practice, it also allowed me to expand my private practice in a better way. The how came about after lots of discussions. Obviously, lots of legal documents in terms of drawing up an agreement and so on. So
without necessarily going in divulging business secrets or details that you don't want to, what's the setup? I mean, how do you guys work together? Are you I don't know.
So from a clinic point of view, we're partners in the company, let's say. So I guess it's not a partnership in terms of what a partnership agreement is. It's a company, but
you're both shareholders.
Yeah. So from a clinic point of view, we're shareholders, split things evenly. Yeah. But Nora Nugent patients are still Nora Nugent patients under Nora Nugent practice. Mark Pacifico patients the same. So we still have an independent personal private practice as well.
And just again, I don't want you don't have to tell me anything you don't want to, but so you're 50-50 partners, but how did that suddenly come about? I mean, Mark may want to answer this better, but having done it all on his own, what suddenly made him want to take on a partner, do you think? And what made you want to work with a partner? Because I don't have a plastic surgery partner in this clinic, and that was deliberate. I decided I'd never agree on anything, not even the colour of the gloves, let alone how to run a business. So yeah, how did that come about?
So I'll let Mark speak I know you're planning to do a podcast at some stage with Mark, so I'll let him answer from his side. Sure. Hopefully he felt it would be a beneficial partnership.
Yes.
From my perspective, the next step I felt for me in my private practice was to have my own operating facilities. So that was number one. I did consider my own, as in just me, but I was already in Purity Bridge and working well with Mark, and he was open to a partnership and growing the business together. And also,
did you guys expand at the same time?
We did expand at the same time into the building next door. So, and it's like anything. The building seems very big when you first move into it, and suddenly it's too small. That was how the first building went. The next building came up, so that has worked well to allow us to expand. So that was happening simultaneously, and honestly, I think that would have happened whether Mark and I had joined forces or not. I think that would have happened, but it did coincide with those discussions as well.
And then you've built an operating theatre there. You've got your GA theatre. How's that going?
That's made the world of difference to us. That's been a game changer. It's allowed us a couple of things. It's allowed us to set up for general anaesthetic day case aesthetic surgery procedures the way we would want to. As most of my colleagues will know, and as you know, plastic surgery takes a greater or a lesser priority in hospitals that do multiple specialties or are part of a multiple chain company. And sometimes plastic surgery very much is a low priority. It also, some of our patients are aesthetic patients with very different expectations, very different needs to some other private patients. And I'm not saying that they're more or less important, that needs are just different. For example, someone having a hip replacement or a knee replacement, the requirements of aftercare are totally different. And when you have a plastic surgery clinic, we have a small team, but they are a team that, one, are very experienced in this sort of surgery, and two, work with us all the time, so they know how we like our patients looked after. So it runs very, very smoothly in that aspect.
And then I wanted to talk to you about, our experience here, for example, with doing day case, general anesthesia, plastic surgery, amongst other stuff. I think has been a game changer as well. And it's, I was chatting to another colleague, Matt James, we recorded another episode. And I think it really is making things, I think, better, not only more efficient and potentially, more cost efficient, but I think we're doing surgery much more effectively with, non-opiate, TIVA-based GA.
Totally agree. Totally agree.
So,
and it's a better patient experience, actually, for the most part. We get very good feedback from our patients. Our anaesthetists work very closely. And in fact, when we first mooted this idea, we involved them from the beginning, and this was Mark mainly at that time. And we involved them from the beginning in terms of setting things up to ensure that they were happy with the setup as well. And we use TIVA exclusively as well.
And it's, it might, with a bit of luck, it means that, we can hopefully start competing with some of the cosmetic tourism options that are out there that we,
Well, I think we can show that we can provide safe plastic surgery and high quality plastic surgery with good aftercare.
Yeah, absolutely. Because I think that's something that finally because the trouble is it is cheaper to go abroad.
I think we're never going to be able to fully compete on price.
No.
But we can most certainly compete on quality.
Exactly, and safety. Yeah,
and
exactly.
safety.
Yeah, absolutely. And now that you're a fully fledged partner, what's your average day? What's it like? Running a place. I can tell you what it's like from my point of view, but I want to hear yours.
So it's definitely very different to running an individual practice, because not only are you running your individual practice, you're also running the clinic. And it brings increased staffing, and with more staff come more things to arrange for staff, or problems to iron out,
the HR,
or more HR issues. The costs are dramatically more than running an individual private practice. So you have to budget properly, you have to grow the business, and you have to be very actively involved in the business. It won't run without us. A good clinic manager, I think, is key to success, and your only chance of having the clinic run in any way independent to you.
Absolutely.
And I think it's also the realization that you ideally don't want a clinic relying purely on you or the owners. You want a team, and you ideally want a team of surgeons involved as well.
And that's what I was going to come on to, is that you having had a very busy couple of years, I'm guessing have been absent more than
usual.
But so does the place function independent of you now? Are you getting to that stage?
We not as much as we would want, but we are bringing in new surgeons, and we have plans for the future. You're right. I haven't. When you're involved in something like BAAPS or ESAPS, it does take time out of the clinic, and that hits harder when you have a clinic than when you're in an individual private practice. We also still like education and training, and the surgeons actually that are coming in with us are, for the most part, surgeons that we worked with when they were in training, when we were in East Grinstead and so on as well. So we're bringing in people that we know and like and trust, and it makes you change your perspective. It's not so much, we don't want to compete with them. We want to grow their practices.
And how are they coming in as sort of, I don't know, almost employed surgeons, or how does that work for new surgeons that are joining you, or If there is a new surgeon that's thinking of
So
coming and
I'm
working
not
with
going
you.
to say specifically what the people. I don't want
No,
to
no,
divulge
no,
any
no,
religion,
no, no, no,
but
no.
we basically offer people the choice. So there are sort of two models: the
Yeah.
sort of independent surgeon who rents the facilities effectively,
Yeah.
or the surgeon who's more integrated with us,
Yeah.
and sort of follows the Purity Bridge path. Let's say.
And you provide patients for them.
Yeah,
kind of
and
thing.
so
Yeah,
on.
and
So
then-
we basically give them the choice,
Yeah.
and ultimately it's down to them which way they want to go.
absolutely.
And of course, things change. You know, in your first 5 years of practice, you would do things differently to your second 5 years. So obviously, this might change as time goes on and people are more established in practice.
And so now, you've been president, you're running a business, you're expanding a business, you're a plastic surgeon in your own right. Would you tell your successors to do all of those at the same time? Or would
No,
you?
I don't think I would. I would say maybe you don't need to do everything all at once.
Yeah, that's right.
Maybe
I think, I mean, that's
it
incredible.
takes up a lot of time.
Absolutely, yeah. Have you managed to sleep these last few years?
There have been some very busy weeks,
Yeah.
but you learn how to juggle things a bit.
Yeah.
Having said that, it's peaks and troughs. You have other weeks where, the society work doesn't impact as much.
Yeah.
So you have some busy weeks, some quiet weeks. So maybe not ideally planned out, but so far so
I
good.
mean, that's the trouble. It never, it's impossible.
Things
to plan-
arise at the
Yeah,
time.
exactly, and so,
And I
so
think that's
guess,
the other point I would say to people is don't be afraid if an opportunity arises that fits what you would ultimately like
Yeah.
to do.
And there's what I would
don't
say
wait too long for things.
exactly, and what I would also say is there's always a way of coming up with a reason to say no.
Yes.
So yeah, so now that you hopefully are emerging out of a very busy period, perhaps the busiest period of your career, what's the advice? What's the takeaways for those who are following on from you?
I think the takeaway would be if this is something you would like to do, put yourself forward and do it. It will be busy, but it actually is very rewarding as well. And it opens up opportunities that you might not realize in terms of places to go or people that you meet, and that also can help you in other aspects of your life or your professional life as well. So I think stay open-minded and take your opportunities.
Yeah, and I couldn't agree more. Actually, I think I never planned out my career path. I never thought I'll let me get to this point and then I'll do that. Then I'll start a private practice. Then I'll do this. Then I'll do that. It all just kind of happened.
And you have to go with it at
and you
times.
go with it. And actually, there were surprising lessons from, I don't know, the one I always quote is I became clinical director at King's, and that sort of taught me how a hospital works. And I don't think I would be
here
part
in your
owner
capacity
here in this hospital if I hadn't started off doing that. And so I think you're absolutely right. Just take things are usually more interesting than you think. And
take your opportunities.
Yeah.
But also if something's very clearly something you don't want to do, don't be afraid to say no to it.
Yeah, absolutely. Yeah. I do not want to be clinical director again.
Once is enough.
Exactly, that's for sure. And having done it, and I would. They asked me if I wanted to stay on. I was very clear I didn't want to. And so let's move on to a topic that's been spoken about a lot, and we've touched upon it briefly. Cosmetic tourism. Now BAAPS has done a lot of work on working alongside some of the countries where we see problems, I guess. We don't know the denominator. We only ever see the few really bad problems coming into
And
our
we know
NHS.
there are good and bad surgeons in every country,
exactly.
and we know there's a high standard of care in the common countries.
Exactly. So how has BAAPS, I think, has done a really good job of trying to tidy up some of the mess. So you talk through first of all what's been done, and then
Where
what
we
your
are
thoughts
now.
are. Yeah.
So in terms of what's been done, you're right, we don't know the denominator. We don't know exactly. You can have estimates of how many people go, but we do know that there are a significant number of people returning with complications. And it may have peaked now. I think it's probably peaked now, not rising anymore, but there was a period where those numbers were increasing.
Yeah.
And we didn't have proper data on it. So we started a database, and this was sort of overseen by Mike Tyler primarily, to collect data for members or indeed non-members as well, to submit non-identifying patient data on type of complication, what treatment was needed, where the original surgery was done and what surgery was done. Fairly basic information. And it did lead to some interesting data. And although it was very incomplete, believe it or not, it was the best data out there in terms of complications. And a couple of things came to light. One, the most common country, and to no surprise, it's Turkey for the UK.
Yep.
That doesn't mean all Turkish surgeons are bad or anything,
Or all
but it's the most
hospitals
common.
bad. You know, there were good hospitals, good doctors in all
The
these
numbers
places.
say Turkey is the most common.
Yeah.
And in terms of procedures, abdominoplasty was the most common procedure to have a complication, and the most common complication was some form of wound healing or infection, and repeated debridements needed, and so on. So we did collaborate with our Turkish counterparts in the Plastic Surgery Society there to say, well, look, if we can't stop people from travelling. If someone is going, what should they look for in Turkey for a mark of quality? And they gave us some good guidelines, you know, to know what a properly credentialed Turkish surgeon is. We drew up general cosmetic surgery travel guidelines. If you are going to go, this is what you need to consider before you go. You know, education is key. We know that the main issue is price. It's not the only reason people travel, but it's the overwhelming reason why people travel. But the things to consider are, you know, is it too good to be true, even for that country? Who are you going to see? Is it a proper plastic surgeon in a proper hospital? Will you see them beforehand? And if so, how soon? How committed are you before you see your surgeon? What's the aftercare? What happens if there's a problem? Every surgery has complications, and every surgeon has complications. But there's an added layer to it if you're either stuck in a country overseas, unable to get back unexpectedly, or if you're at home and you can't get back for the aftercare. That's where the difference in travel really comes out. It's you can't access the aftercare you would otherwise be able to access.
I think that's been, that is the biggest difference. And I think it's a failure of aftercare more often than not, rather than a failure
and routine aftercare is needed anyway, and you miss some of that.
Yeah, absolutely.
You know? So where do we go from here? The Department of Health has taken an interest in it, and we have had lots of discussions about how to move things forward. We lost a little bit of momentum on it with the non-surgical regulation, but again, the Women and Equalities Inquiry did include that in their publication. But it's how to go forward. You know, there are a few routes you could go. It's education of patients. Can the equivalent care be provided at home that they would access instead? Or if they're going to travel, is there some way of implementing insurance, which is obviously very tricky? And it's then other things like, what about local networks? For example, ISAPS would be, or ESAPS would be an example of a European or international network in terms of accessing aftercare. But obviously that has to be relatively equal. It can't be a one-way stream as well. So there are there's no perfect solution, and you cannot stop people from travelling if they wish to.
Absolutely.
I think we're making some progress in the public mindset, though.
I've started to wonder about whether UK surgeons should go and work in Turkey and then do the aftercare in the UK. Maybe the surgeon should travel, not the patient, as it were. Well, with the surgeon should travel with the patient rather, and then be at home with the patient.
And surgeons travel as well, so that is not unheard of.
Yeah, maybe.
Just not as common a model.
No, let's see how that goes. Yeah,
but I think it's hard enough to know in the UK who an accredited plastic surgeon is. It's even harder overseas, because every country has a different accreditation or licensing system. So you have to know what you're looking for.
Absolutely. I mean, we see that, with ESAPS and ISAPS, that's where it is so different around the world. But it's good, at least now that, we're the good thing is, I think, good surgeons talk to each other.
And good surgeons also make arrangements for these things. Or advise the patient how long to stay, how when to get, if it's a long haul flight, how soon before surgery to arrive, things like that.
If you do get home and run into trouble, this is how you get hold of me. And you know what? I know someone who I can call if you're not able to come running back to me, because you might be too unwell, I guess. That sort of,
I mean, some based on the data we collected and talking to colleagues, some people would be too unwell to travel back.
We've had patients in ITU who obviously can't go anywhere. But at least, if we're able to talk to the original surgeon, which that's the problem. If
you've got a line of communication open, and also for the more minor issues, if the patient's able to access advice at least.
Exactly. So, I think we've covered quite a bit. I mean, this is the point at which I ask you: is there something that I have missed out that you desperately wanted to talk about? So, what have we not spoken about?
I think we've covered a lot of ground.
We've covered a lot, yeah, and actually not that, pretty compact.
From medical school up to now,
Exactly.
and the future.
From Ireland all the way to Australia, yeah.
and back again.
Absolutely. No, thank you very much. No, I think it's been a really nice chat. I hope you guys have enjoyed it. And the last question is, if you went back to, say, I don't know, when you were, let's pick a time, when you were doing your higher surgical training in Ireland, say, what advice would you give yourself to that trainee?
I think it's realizing that all the periods of uncertainty, for example, getting a training number, coming off the end of training, all of them come to an end, and something generally turns up. So not to get too anxious about the next step. Look ahead, but don't get too anxious about it, and keep an open mind. There's more than one way to do things and more than one route to everything.
Don't plan too hard.
Don't plan too hard, and see what comes up as well.
Yeah, usually interesting things come up. I think that's the great thing about it.
And if something interesting comes up, don't not do it just in case it stops something, you know.
Generally speaking, that's the good thing about being a plastic surgeon, is that we're usually exposed, intentionally, unintentionally, to interesting opportunities, interesting things. And I think most of the hats that I've put on in my career have generally been fun, and I've not regretted.
And the uncertain periods come to an end.
Yeah, exactly. I think in a funny sort of way, it does get easier.
Yeah,
it doesn't get any less tiring.
No,
but you don't mind being so tired, maybe.
And you change your mindset as well. You what you once considered absolutely vital, maybe 5 years later, is not actually that vital.
Yeah, it's not that important. Yeah, it's really, that's very true. So so thank you, and it's been really nice having you.
Thank you for having me.